The primary health care fund is fully funded by the government to a tune of 4 billion. The emergency, chronic, and critical care is funded to about 2 billion. That is, you might ask yourself, this might be a very small amount compared to many Kenyans. But not everybody is sick. The biggest challenge today that we face is that many people want to register when you become sick. The authority is called Social Health Authority. And this authority, that is the SHA. This authority was a creation of this House. It runs 3 funds: the Social Health Insurance Fund, the Emergency, Chronic, and Critical Care Fund, and the Primary Health Care Fund. All the 3 funds now replace the one fund which we had, the NHIF. NHIF had a lot of many problems and challenges. And the previous governments have tried to see how best we can be able to introduce the universal health care. We had pilot projects in Nyeri, Machakos, Kisumu, and other areas to see how we can be able to introduce this. When President Ruto came into government, he brought bills to be able to operationalize how can we be able to achieve universal health care as one of his projects, as one of his agendas in the manifesto of UDA and Kenya Kwanza. In this, we passed the Digital Health Authority, Digital Health Bill. We passed the Social Health Insurance, the Social Health Authority Bill, and we also passed the Primary Health Care Bill and also the Facility Improvement Fund. Honorable members, on 1st October, the government began rolling out this program on providing of Kenyans universal health care. It is 5 weeks now. In this program, as we speak today, we have several successes that we've seen. Among them, we have 39,000 Kenyans who have attended renal care visits. We have 81,000 Kenyans who have had admissions, 12,000 cancer care visits. We've had 49,000 consultations at the primary care. And what is the impact on this? That we've had renal and hemato-oncology, 430 million approved for life-saving dialysis care over the past 5 weeks. We've had more than 300 million approved for cancer care. The average turnaround time for pre-authorization has now improved. Initially, we had challenges, but as we speak today, the turnaround time is 2 hours. We've had challenges in terms of private hospitals, in terms of accepting and running this program. But in the 4 major hospitals, referral hospitals, that's the Moi Teaching and Referral Hospital, Kenyatta National Hospital, Kenyatta University Teaching and Referral Hospital, Mathare Hospital, Spinal Injury, all these hospitals, as we speak today, there is no single patient who has gone there and been turned away. NHIF had a lot of challenges. In it, we had close to 12 million as beneficiaries of NHIF. Out of that 12 million, when the system was connected to the National Registration Bureau, 9 million Kenyans were found to be able to be transferred from the NHIF system to the SHA system. And that is where you got messages telling you that you are now transferred to the Social Health Authority. You can access Social Health Insurance Fund, which you contribute about 2.75, while the Primary Health Care Fund is fully funded by the government to a tune of 4 billion. The emergency, chronic, and critical care is funded to about 2 billion. That is, you might ask yourself, this might be a very small amount compared to many Kenyans. But not everybody is sick. The biggest challenge today that we face is that many people want to register when you become sick. And when the Social Health Authority, together with the CS, appeared before our committee, one of the commitments which we've asked them to do is that in every constituency office, they are going to release a letter so that at every constituency office, you can now register people so that it is possible for you not to register at the time of seeking treatment, but to register in advance so that when you just go to the hospital, you're already a registered member. If I can ask for just one more minute, Mr. Speaker. So this is important, honorable members, because you have indigents, you have people who cannot be able to pay, and these are the people who expect the government to pay for them. Therefore, by registering within your constituency or within the women reps or even the senators' offices, we can use the means testing to identify.
1 minute because of the information is giving being committee chair.
The Social Health Authority, together with the Digital Health Agency, will send their staff so that they can liaise with your constituency office managers and your team so that your constituents can be registered, and through means testing, we can be able to pick those who are indigents and they can be able to access services so that the government can pay for them. Because in our budgetary allocation, we have an allocation that we allocate for indigents. And I think these are the largest population that will come to you seeking for your assistance. So as soon as that letter comes, I'll be able to forward to and we have asked them to forward to the clerk so that all members can be informed and you can be able to inform your constituents. With those few remarks, Honorable Speaker, thank you for allowing me to contribute.
Shif itself is okay in bit because of the people who are employed and therefore easy to catch. What about people who are self-employed? What about the indigents? What are we able to do to them now? And that is where the problem is, because they can register. And even when they register, then you have to determine the premium they have to pay. As it is now, that is not working well. You will say I'm registered, but how much premium am I supposed to pay? It does not come quickly. And then even when you get the premium, the existing ERP that is supposed to help you how to pay is also a problem, which has been a problem even for employed people, but that is now improving. So those are the problems. So now, those who are self-employed, we are saying we are going to use means testing. They test themselves. Now, when people give this data of their employment and you say, okay, you are supposed to pay this much, how do you verify that? And are they able to pay now? And what is the system of payment? That actually is still a problem. When we talk of the indigents are people who cannot pay. And let me say this, you cannot do proxy means testing online. All over the world, nobody has ever done proxy means testing online. Because what is used, the proxies that are used themselves cannot tell you the proper means. It is always at one point you have to get to the ground and see the family. You cannot say this is a stone house and it tells you the income of the family. You have to go and see what form of stone house. You cannot say this is a mabati and not a thatch. It is maybe some tin shack mabati. So you have to do that. We have a problem there. It is exactly the same problem we have with university funding. So we really have to go for proxy means testing and do it the way it should be done. We can use the community health promoters, but so far, and even the chiefs and the assistant chief, but so far, at least in my constituency, I've not really seen this thing working. So that is exactly where the problem is. And even these who are to assess themselves. So now, what has happened, because we have gone up in the payment, those employees who are paying a lot more now are actually covering up. What about those who are self-employed and have not enrolled, and you have not know how much they enroll? And now I know when we tested this in Eldoret, they actually, you can get and say it is registered. You are registered, you have not paid, but because you are in a hurry, we are saying you can go and get the service. Now, if you are getting the service, you have been registered, but you haven't paid. what is going to encourage you to pay? So we have problems, and the system we have put in place, it affects everything from registration, premium determination, payment of premium, benefit package. Even the benefit package, we went up because we were expecting more money. And in the primary care fund, the emergency fund, we actually were expecting 70 billion, say 75. We have done 4 and 2, as my colleague is saying. But you know, the services, the benefit package we gave was based on that. So if that has not come and we are giving the services, where is the money coming from? If we don't do it and it is working efficiently, what is going to happen is very soon we are going to run short of money because we have not got that fund in. We have not enrolled people who are self-employed. We have not even identified the indigents. But because we want things to look good, we have